is by Mahaboob, Basha, Shaik, GATT challenges for beginners. Dr. Basha is here.
Good evening all. On behalf of VST Center for Glaucoma Care, LV Prasad Eye Institute, Hyderabad, myself Dr. S.M. Basha, glaucoma consultant. I would like to, as everyone knows, as Dr. Vanita was just telling, GATT is trending now, especially the mixed microinvasive glaucoma surgery. I thought of one presenting a intra-op complication, that is ciliary body cleft and its management. A 60-year-old male diagnosed with angle recession glaucoma, post-blunt trauma with significant cataract in the right eye. Baseline IOPs were 40 mm of mercury. Best corrected visual acuity was 20/30. Gonioscopy showing open angles in both the eyes with 360-degree angle recession in the right eye. Optic disc in the right eye showing 0.9 cup disc ratio with broad inferior notch. And left eye was fine except for early cataract changes. He was started on topical anti-glaucoma medications in the right eye. Later in subsequent follow-ups, his IOP was still high. Hence combined surgery was advised. As gonio is open angles, we planned for phaco with IOL with GATT in the right eye. One of our trainee has started the case. First we went ahead with the clear corneal phaco, temporal incision. And then after completion of the phaco, one 10-0 nylon suture was applied. And then this is the introduction of 5-0 Prolene suture. I have just taken few snapshots of the surgical video so that for better understanding. So this is the main picture here. So after phaco done, so this is how we do the microscope adjustments and then patient head tilt, that all we all know. So this is the ultimate picture where GATT will start. So here one should appreciate the angle structures. So usually we found two darker structures. One is the pigmented trabecular meshwork and the other one will be the ciliary body band. As the patient is already a known case of angle recession glaucoma, here the ciliary body band it's very widened and it's irregular widening what happens in angle recession glaucoma. So the above line, the darker line is the PTM. Now see here, the goniotomy incision which we do, we are supposed to make the incision at the upper limit of trabecular meshwork, but here we can see the surgeon doing the incision at the upper limit of ciliary body band. Because of, we know that it's not the normal angle because it's been a traumatic eye and also in beginners it happens. So the incision wrongly was given at the upper level of ciliary body band. And then again the surgery was proceeded. And here also we can see whenever the Prolene suture is introduced into the eye, after making the goniotomy incision, the proximal end should be visible. Actually we see when we introduce it into the Schlemm's canal, we can see the proximal end, the tip we can see it is going into the Schlemm's canal. But here we can see absolutely we can't see it is completely opaque. One more, it's an indicator of false passage. Then you can see again while introducing the Prolene suture further, there is more of bleeding also. So when I took over the case and then I just pulled out the Prolene suture in the reverse direction, and then after keeping the visco cohesive, this is what I can see. This some darker structure which was not there previously, that is what is ciliary body cleft. So usually we see less commonly the CB cleft because we see hardly in post-traumatic eyes, but this is the intraoperative iatrogenic CB cleft. 2 to 3 clock hours I noticed, and then I just abandoned the surgery. And then the post-operatively day 1, the best corrected visual acuity was 20/100 with IOP of 10 mm of mercury. Patient was started on antibiotics, steroids and cycloplegics. As I am very sure the CB cleft was there on table, I started on cycloplegics as well. At 1 week, the best corrected visual acuity was 20/50 with IOP of 15 mm of mercury. Gonioscopy showed nasal ciliary body cleft. UBM on same day confirmed a nasal ciliary body cleft with 360-degree ciliocoroidal effusion. Same medications were continued. This is the UBM picture. I have kept in the clockwise pattern. On the 3 o'clock hour, we can see there is CB cleft, some discontinuity with the coleochoroidal effusion, and then at 6, 9 and 12 all clock hours showing the coleochoroidal effusion. Subsequent follow-ups showed slow increase in IOP, and at 1 month visit there was an IOP spike of 40 mm of mercury. So why this happened? As we know, intraoperatively the aqueous is going back. So definitely in the we won't see IOP spikes immediately. So as now we have not done anything glaucoma surgery for the patient. It was an intraoperative complication. We just went ahead with the fake one and we abandoned the surgery. So this was expected only, which at 1 month we saw IOP spike of 40 mm of mercury. And then on that day, the clinical evaluation and UBM showed resolution of choroidal effusion, stop topical steroids and cycloplegics, and was started on oral and topical anti-glaucoma medications. In the next couple of weeks, the IOP was still high on maximum medical therapy. Subsequently, we planned for trabeculectomy. So this is how we can see at the 1 month post-op. There is no CB cleft, there is no coleochoroidal effusion at all in all different clock hours. So to conclude here, cycloplegic drugs are the mainstay of medical therapy, which cause relaxation of the ciliary muscle tone and dilatation of the ciliary body ring, and will help to oppose the detached muscle fibers to the sclera. The role of topical steroids is still debatable. Some will tell increase the steroid use, and some will tell to reduce steroid use to promote inflammation and cilioscleral adhesion. So as the angle-based surgeries are on the rise now, understanding various complications, their identification and management are important for the beginners. Creation of false passage is likely to occur while one starts doing GATT or goniotomy if the incision is too deep or higher or lower. As it was lower in our case, the surgical field should always be clear and visible on gonioscopy lens. After making the trabecular sheath, the passage of Schlemm's canal should be visible to confirm the entry of Prolian suture. And also after a certain length of suture has passed, not visualizing the suture in the opposite side canal, or noticing unusual iris movement or pupil peaking, or patient experiencing pain in spite of local anesthesia, or excess bleed while procedure is progressing, all are the signs of suture not in the correct location, and one may need to stop the procedure and relook at what is happening. So one can proceed with the procedure in the opposite direction and complete the surgery. In the event of any complication noted, like how in our case, better to perform a goniotomy if possible, or an abundant GATT, or manage accordingly based on the response rather than worsening the problem. So as GATT is now increasing now, so I would like to request whoever is doing GATT, please come up with your experiences, and whoever not yet started, yes, you people can start. Yes, I agree, intraoperative, it's not that easy, the learning curve is there, some complications will be there, but how I showed, complications to the great extent we can manage easily. So then wishing all the best for GATT in future. Thank you.
Dr. Basha, I have a question here. I don't have that much experience with GATT, maybe you're better in it. So do we do GATT in such cases, angle recession, glaucoma, goniotomy and GATT? Is it being done abroad, or how are the results?
Yes, in open angle glaucomas we are doing. Is it primary or is it secondary? Yes, we are doing. Yes, we are having good results, and the study is going on. Open angle glaucoma, previously we used to take almost all cases, but nowadays the very advanced glaucoma we are not taking. And what importantly we are looking is the locality of the patient also, from where the patient is coming and how much is his understanding ability to explain about the GATT and the consequences. And patient should be available for the follow-ups as well.
So angle recession glaucoma, we can do GATT?
Yes, you can do angle surgeries. In fact, it responds very well to angle surgery. Steroid-induced as she presented, angle recession as he presented. But I just wanted to go back on your slides, and for the sake of the audience, please point out exactly where the trabecular meshwork is. Because you had still photographs. It's extremely important for people to understand the anatomy of the angle before proceeding. It comes up as a red line. Why is it red? Because in the Schlemm's canal, that's your trabecular meshwork, the red line. Why is it red? Because you have regurgitation of blood in the Schlemm's canal. So that is your trabecular meshwork, and underneath it is the Schlemm's canal. So he should have been at that level rather than below. He's gone into the ciliary body. Yeah. Thanks for being honest and presenting this.